Chapter 21, the Neurologic System. Lesson 21.1, the Neurologic System Theory Objectives. Define the vocabulary particular to problems of the nervous system. Discuss the differences in the action of sympathetic and parasympathetic nervous systems. Devise 4 specific ways in which a nurse can contribute to preventing neurologic disorder. Provide rationale for the appropriate preparation and post-procedural care for patients undergoing lumbar puncture or spinal tap. Also electroencephalography and radiologic studies of the brain and cerebral vessels, demonstrate techniques used for assessment of the nervous system, and compare and contrast the various signs and symptoms of the common problems experienced by patients with nervous system disorders. Clinical practice objectives. Gather a pertinent history for a patient with a nervous system problem, demonstrate a neurocheck, score the neurologic status of a patient with a nervous system disorder according to the Glasgow Coma Scale. Anatomy and physiology of the nervous system. Organization of the nervous system. We know that the nervous system is composed of 2 primary parts, the central nervous system and the peripheral nervous system. The central nervous system is comprised of the brain and the spinal cord. The brain has 4 parts, the cerebrum, which helps with sensory info, voluntary movement, some involuntary movements, thinking, learning, language, judgment, personality, and memory. The diencephalon, which is comprised of the thalamus and hypothalamus and controls our body temperature, appetite, and water balance, and also links the nervous system to the endocrine system. The cerebellum, which coordinates our movement, posture, and muscle tone, as well as our balance. And the brainstem, which is comprised of the midbrain, the pons, and the medulla, and helps with our visual and auditory reflexes, controls our cranial nerves 3 and 4, controls eye movement, regulates respirations, heart rate, blood pressure, controls swallowing, coughing, sneezing, and vomiting. As we talk about the peripheral nervous system, the peripheral nervous system gives sensory information to our brain from our sensory organs. It also has distribution pathways of spinal nerves that are called dermatomes and 12 pairs of cranial nerves. Okay. When we talk about the interaction between the CNS and the PNS, we have to talk about the afferent and afferent division of the PNS. So the peripheral nervous system has an afferent division, which carries impulses to the central nervous system from sensory organs, and an afferent division, which carries impulses away from the central nervous system to sensory organs. The reflex arc is a simple conduction pathway that uses a receptor or sensory neuron that's centered in the spinal cord and a motor neuron located in the effector or the skeletal muscle. So a stimulus will travel from the sensory receptor through the spinal cord and back to the effector, which causes action. Reflex arcs are very important to most functions of the body, including staying upright. Cranial and spinal nerves. When we talk about cranial and spinal nerves, we need to know that they're part of the somatic subsystem and they respond to changes in the outside world. Because they initiate voluntary action, the somatic system is called the voluntary system. Okay. The autonomic system of the PNS is active in maintaining internal body balance like homeostasis and automatic or involuntary actions. Okay. The autonomic system can be divided into 2 different categories, the sympathetic and the parasympathetic system. So what we know about the sympathetic system is the sympathetic system mobilizes energy to initiate changes aimed at maintaining or restoring homeostasis. So that is good. The parasympathetic system conserves and restores energy that has been used to maintain homeostasis. So the sympathetic and parasympathetic nerves often have opposite effects on many organs. While we're here, I just want to kind of talk about some of the cranial nerves and their functions. The olfactory nerve is cranial nerve 1, and that helps us to smell. The optic nerve is 2, and it helps with visual acuity, field of vision, and pupillary response. it comes on an afferent impulse. Oculomotor is the third cranial nerve, and it helps with eyelid elevation, extraocular eye movement, pupil size, convergent, and pupillary restriction. It's an efferent impulse. The trochlear nerve is nerve 4, and it helps with excuse me, extraocular eye movement, inferior and lateral. The trigeminal nerve is the fifth cranial nerve. It helps with the corneal reflex, facial sensation, chewing, biting, and lateral jaw movement. The abducens is the sixth cranial nerve, and it helps with extraocular eye movement, lateral. The facial nerve is the seventh cranial nerve, helps with taste, facial muscle movement, including muscles of expression, and lacrimal gland and salivary gland control. The acoustic nerve is cranial nerve 8, and it helps with hearing and sense of balance. The glossopharyngeal nerve is cranial nerve 9, helps with sensations of the throat, taste in the posterior tongue, gagging, and swallowing. The vagus nerve is a big nerve, cranial nerve 10. It helps with sensations of the posterior tongue, the throat, the larynx, impulses from the heart, lungs, the bronchi, and the GI tract. It also helps us to initiate swallowing and phonation. Spinal accessory nerve is cranial nerve 11, helps with shoulder movement and head rotation. And the hypoglossal nerve is cranial nerve 12, which helps with tongue movement and articulation of speech. This is the structure of a neuron. So if we look at it, we see the cell body, the nucleus and nucleolus of the cell. We see the dendrites or the branches coming off of the nerve cell, excuse me. We also see the axon, which connects to the Schwann cells and the synapses. As you move down the axon, you see the node of Ranvier. You see the direction of the impulse. We're going to the synapse. We're going to the organ. And then as we look at the Schwann cell, we have a nucleus, the neurilemma, the myelin. The demyelinization of this is where it happens when we lose those nerve sheaths, and it causes something called MS or multiple sclerosis. We also have collateral branch coming off of the side of the primary axon. And then you see the telodendria connecting at the synaptic bulb. Very, very delicate and intricate structure of a cell. It's a very interesting cell. So here is just a visualization of the main divisions of the central nervous system. You're able to see the cerebral hemisphere, the diencephalon, which is your hypothalamus and your thalamus, the brainstem, which is that midbrain pons and medulla, the cerebellum, and then the spinal cord. The corpus callosum is the connection between the left and right hemispheres of the brain. And then the close-up there, you're able to see more clearly the hypothalamus and thalamus, and also the pineal gland, the optic chiasm, and the pituitary gland. Functions of the divisions of the brain. We already kind of talked about all of these functions. If you have any additional questions, don't hesitate to reach out. Specialized functions of the lobes of the cerebrum. So the parietal lobe, what does the parietal lobe do? Sensory, sensation, some motor. The frontal lobe is going to be the personality and behavior, intellectual functions, and some motor. We know that the frontal lobe is what is less mature or formed in the young adult or the adolescent, which results in impulsive behaviors. The temporal lobe, we've got hearing and smell, auditory receptive, and the occipital lobe, we have some sensation and visual association. Here are the dermatomes that we talked about being connected to that parasympathetic nervous system. So you can see that they've split them up, and each particular dermatome has a name assigned to it. Just some things to mention here before we move forward. The brain's neurons, so that those nerve cells that we looked at, I'm going to go back to them. They cannot survive if they've been without oxygen or they've been anoxic for more than 4 to 6 minutes. Okay. We know that the brain gets blood flow through the carotid arteries on the right and left side. That's why we only palpate one at a time. We don't ever palpate them together. We also know that venous blood exits cerebral circulation via the jugular veins. That's where we get things like EJs and IJs. As far as central lines. Um, and then intracranial pressure. So as we look at the brain here, the brain is inside of that skull. It's very important that we maintain an appropriate intracranial pressure. The normal pressure within the skull is 5 to 15 millimeters of mercury. If we get above that, the brain doesn't have a whole lot of room to go places, to move. So brain tissue, cerebrospinal fluid, and cerebral blood are going to determine the intracranial pressure. Disorders that cause swelling of the brain tissue or increased cerebrospinal fluid or increased blood flow will all increase intracranial pressure. And if you have an intracranial pressure greater than 20 millimeters of mercury, you definitely need to do something. Prolonged elevation of ICP is going to compromise the brain tissue. Why? We'll probably have ischemic injury and also death of neurons. Additionally, we may herniate. Once we destroy our brain cells, they cannot be replaced. However, the Schwann cells in the peripheral nervous system can regenerate their myelin sheaths that wrap around the axons. So as folks age, let's see if we've got one. We talked about the cranial nerves and their functions, components of their generalized reflex arc, overview, neurotransmitters. Let's jump to this age-related changes slide. So as people age, we lose neurons and we also decrease in functioning of our neurons. There's decreased blood flow to the brain. Body homeostasis is more difficult to maintain and regain. Short-term memory may be affected. There's a decreased secretion of norepinephrine and dopamine. The posterior root nerve fibers and parasympathetic nerve fibers are declining. In the peripheral nervous system, the motor nerve fibers and the myelin sheaths start to degenerate with advancing age. Reflexes may be diminished or absent. Pupils may decrease in size. Older patients, what does this mean? What's the applicable concept from here? Well, older patients may need more time to process questions, to solve problems, to learn new information. Using the brain and keeping it active help to promote continued intellectual function in healthier older adults. If you don't use it, then you lose it. In late adulthood, we start to see changes with decreased sensation as well. Older folks may start to tremor even without rigidity, and they may start to develop those hypoactive tendon reflexes. Older people are more prone to issues resulting from prolonged exposure to cold or excessive heat because they're not as easily, or excuse me, they're not able to as easily regulate their temperatures. Also, physiologic stress is going to take the older adult a lot longer. Sometimes they don't ever truly recover from tremendous stress on their body. We know that short-term memory is affected. Most oftentimes, long-term or distant memory is not affected. And although everyone can learn, you can teach an old dog new tricks. The learning process may be a little bit slower in the older adult, and their abstract reasoning ability is going to start to slow down as they get older. Their perception may also be impaired. And then the reason why we need more light for reading, so we need extra light and reading glasses. Our pupils decrease in size with advanced age and we're not able to take in as much light. Okay. Let's go back to the neurotransmitters that affect the transmission of nerve impulses. What are the big neurotransmitters? Well, we want to talk about the ones that we so often replace. So serotonin is a big one. It is made in the central nervous system. It's usually inhibitory. It's found in pathways that regulate temperature, sensory perception, mood, which is a big one, and the onset of sleep. Dopamine is found in the central nervous system and peripheral nervous system. It's an excitatory neurotransmitter. And dopamine is found in pathways that regulate emotional response. And there are decreased levels of dopamine in Parkinson's disease. Epinephrine is found in both the central and peripheral nervous systems. It can either be excitatory or inhibitory, depending on the receptors. It's found in pathways that are concerned with behavior and mood. Norepinephrine is also found in the central and peripheral nervous system and may be excitatory or inhibitory depending on the receptors. It's found in visceral and cardiac muscle, neuromuscular junctions, and cocaine and amphetamines are going to greatly exaggerate the effects of norepinephrine. Acetylcholine is found in the central and peripheral nervous system. Most of the time it's excitatory, but it can be inhibitory in some visceral effectors. It's found in skeletal neuromuscular junctions and also in the autonomic nervous system synapses. There's also GABA or GABA aminobutyric acid. It's found in the central nervous system and it's an inhibitory neurotransmitter. It inhibits excessive discharge of neurons. Then we have the glutamic acid or glutamate. It's found in the central nervous system. It's an excitatory neurotransmitter that facilitates signals between nerve cells and plays a role in learning and memory. And then endorphins and enkephalins, central nervous system, inhibitory. They release sensory pain. They inhibit, the release of sensory pain neurotransmitters. And opiates are actually going to mimic the effects of the peptides. So of the endorphins. Okay. Audience response question. Here's the first one that you have. When providing care for a patient with right hemiplegia from a stroke, the nurse should what? Select all that apply. Remind the patient to pay attention to the left side. Protect extremities during transfers. Support unaffected arm with pillows. Use sling on the affected arm to promote better balance, or initiate range of motion exercises. I will give you a second to determine your answer. The answer is to protect extremities during transfers, use slings on the affected arm to promote better balance, and to initiate the range of motion exercises. Protecting the central nervous system. So this is big, right? We want people to wear helmets and safety attire, be careful when diving and swimming, wear seatbelts, wear PPE when spraying with insecticide, and refrain from recreational drug use. Common neurologic disorders can include genetic or developmental disorders. Examples are like cerebral palsy, muscular dystrophy, Huntington's disease. Trauma can cause neurologic disorder, head injury, a penetrating brain injury, a spinal cord injury, or ruptured intervertebral disc. There are also cerebrovascular neurologic disorders. So like a CVA, a stroke, or a TIA, a ruptured aneurysm, an arteriovenous malformation, and migraines or cluster headaches can be cerebrovascular neurologic disorder. Tumor, like a brain tumor, a spinal cord tumor, can cause dysfunction and disorder. Infections like meningitis, encephalitis, brain abscesses, spinal abscesses, poliomyelitis, and Guillain-Barré syndrome can cause issues neuromuscularly with the neurologic system. And then degenerative disorders. These are like Parkinson's and Alzheimer's. And then cranial nerve disorders such as Bell's palsy or trigeminal neuralgia are also a type of neurologic disorder. Evaluation of neurologic status. So talking about the cranial nerves, we want to make sure that their function is intact. It's also important that we perform an assessment or examination that systematically is going to measure the ability of the body to perform its motor and sensory functions. We need to assess mental acuity, memory, emotional stability. Also, if we're going to do a complete neuro exam, it's going to be very long, and it's not typically indicated for each patient that you're going to encounter in your nursing care. Typically more for patients that have neuro issues. Components of the complete assessment are routinely done on every patient, and more detailed evaluations are completed for patients with neurologic disorders. We want to assess cognitive function with every single patient we come into contact with, and we know that cognitive changes can be the first sign of hypoxia, a drug reaction, or any other condition that may affect the nervous system but is not caused by disease process. It's very, very, very important that we control hypertension and cholesterol with patients that have nervous system disorders or just patients in general. Why? Because both by controlling the hypertension and also controlling cholesterol, we can reduce the number of strokes and the damage that strokes will cause. We also need to explain the FAST technique to people so they can recognize symptoms of stroke and seek early treatment to prevent uh, permanent disability. We will talk about that FAST terminology later. Okay. Sorry about my pug snoring, you guys. You know, they just love it. Love snoring. Quick gross assessment of major cranial nerves, the olfactory, optic, oculomotor, trochlear, abducens, trigeminal, facial, vestibulocochlear, glossopharyngeal and vagus, spinal, accessory, and hypoglossal nerves. So you need to make sure that we're assessing the nerve responses to make sure that they're performing the appropriate function. Like I said, this in-depth neuro assessment would only be completed on a patient that may have previously had some kind of neuro disorder. We talk about normal and Babinski reflexes. If you do a line of stimulation from the outer sole, the heel to the little toe up, a normal reaction is a plantar reflex where the toes are going to curl inward, right? If the patient has something else going on, let's say that they're on drugs or they have some neuro um, uh, deficit or trauma, something's going on neurologically with them, or if they're a baby, their greater toe will bend upward and the smaller toes will fan, their toes will go the opposite direction. Knee-jerk reflex or a patellar reflex. This is where we hit the knee with the little hammer. I'm sure you've heard of this. It tests nerve pathways to and from the spinal cord at the level of the second through the fourth lumbar nerves. Also, we'll do this. We'll also do a neural exam to include the biceps reflex, the triceps reflex, the brachioradialis reflex. This is going to test the other cranial nerves. So we talked about testing the cranial nerves. This is going to help us to test function. The fifth, the sixth, and the first and the second sacral nerves as well. We'll grade these reflexes based on a 0 to 5 scale. 0 will be absent reflexes, 1 will be weak reflexes, 2 or +2, 2 plus is normal. 3 is an exaggerated response, 4 is hyperreflexia with clonus, and then 5 is severe issues up to seizure. While we're speaking about clonus, clonus is the continued rhythmic contraction of a muscle while there's continued application of the stimulus. And we watched great videos about clonus in lecture. And then we learn about the oculocephalic or doll's eye and oculovestibular reflexes. So these reflexes are very interesting as we are able to test them in our patients that have neuro issues to see what's going on with their neuro status. So one thing that we will do with doll's eye or the oculocephalic test, we will check to see if the patient is able to respond to the light and also if the patient is able to follow a finger. Now, if the patient is unable to have a normal pupillary reaction or follow the finger, we would be concerned that the patient has some type of neuro deficit. Okay. Assessment, so assignment considerations, patient history, physical assessment, we'll do vital signs and mental function, level of consciousness test, we'll look at pupillary reactions and do a short neuro check. Diagnostic tests, wow, are there a ton of diagnostic tests for the neurologic system, right? So we talk about skull and spine radiographs or x-rays. They're going to help us detect fractures or bone loss, and other bony abnormalities. Lumbar puncture is going to help us know if the cerebrospinal fluid pressure is elevated, if there's a blockage to the flow. We also may want to inject medications into that space or culture it to see if there's a bacterial infection. There also may be an EEG ordered or electroencephalography. This is where they put the little stickies all over the head with the paste, the electro paste, and they leave them on for 45 minutes to 2 hours. Sometimes they can do a 24 to 48-hour EEG as well. And it's going to tell us what's going on with the brain waves. Are there abnormal patterns that may be indicative of a disease or a seizure disorder, a brain tumor, cerebral vascular accident, a head trauma, infection? And we also do EEGs to determine if someone is brain dead. MEGs are another type of brain mapping, and they use this in epilepsy surgery. It's a magnetoencephalography, and they use a biomagnetometer machine, which detects the small magnetic fields that are generated by the neurons. And they do this in a magnetically shielded room that blocks out outside signals. And sometimes they do this with an MRI. Okay. Also, we have the electromyography. It's going to measure electrical activity of skeletal muscle at rest and during a voluntary activity. It's going to help determine if there's any abnormalities in muscular contraction or nerve dysfunction, or dysfunction in the nerve to muscle communication. It's going to help us diagnose neuromuscular, peripheral nerve, and muscular disorders. We usually have the patient sitting in a chair, lying on a table, and we put in those ouchie needle electrodes. They get inserted. They may be very uncomfortable for the patient. This test can take up to 1 to 2 hours, depending on how many muscles that we're testing. And because it is an invasive test, it requires a signed consent form. It has to be fully explained to the patient, and they need to know that there may be some discomfort experience when those needle electrodes are put onto them. Myelography detects spinal lesions, intervertebral disc problems, tumors, or cysts. They use contrast medium for this one, and they're able to keep the patient in bed, the head of bed elevated. Afterwards, it's important that we do that as well. It takes about an hour to do this test. It's a really rare test. They're not often doing the myelography with patients. If they do it, it requires a consent form. They may feel that warm peeing my pants sensation that when that contrast medium gets injected. It's important we keep them NPO 48 hours before this, and that we make sure that they don't have any meds that need to be held for 48 hours afterwards because of the contrast. We'll, of course, assess for allergy to iodine or shellfish, assess for pregnancy, etc., and then follow normal post-procedural vital signs, pulses, sensation assessments, urinary output, etc. A CAT or a CAT scan, a CT scan is a computated axial tomography. Oftentimes these are done with contrast, but they can be done without contrast. Lumbar puncture is needed for an intrathecal contrast enhanced CT. We want to examine the brain from many different angles and look at a series of cross-sectional images from the brain to provide views from 3 different dimensions. It's important to identify hematomas, tumor cysts, hydrocephalus, cerebral atrophy, and obstruction to CSF flow, and also cerebral edema. Cerebral angiography is going to help us visualize the structure of cerebral arteries, determine if there's any issues with stricture, tumor, aneurysm, thrombus, bleeding, or hematoma. Because it is a contrast or radiopaque contrast injection procedure, we need the same thing, a signed consent form, check for allergies, check for medication, check for pregnancy. They should be NPO 8 to 12 hours before the test. We want them off of anticoagulants beforehand. They may be given some sedation, some antihistamines or steroids, so they don't have an allergic reaction to dye. And we're going to want to watch for bleeding at the catheter site and assess the distal pulses afterwards and normal post-procedural vital signs. There's radionuclide imaging or just a brain scan. It helps us determine if there's an intracranial mass like a tumor, an abscess, a hematoma, or an aneurysm. There's MRI. It'll help us look at soft tissue. We don't use radiation with this, or the ionizing radiation, I should say. It provides excellent images of the soft tissue, taking away all the bone, and you can really visualize lesions that you can't see on a CT. It also helps to detect white matter areas in the nervous system that may represent demyelinization as well, like in multiple sclerosis. And in MRA, or magnetic resonant angiography, we evaluate intracranial and extracranial blood vessels for diagnosing cerebrovascular disease. It also it has been replacing cerebral angiography as far as a diagnostic test. It is very similar to the MRI. We need the patient to lie completely still for an hour. They may need to be sedated a little bit in order to do that. Of course, they can't have any metal because it is a magnetic resonance test. There's also magnetic resonance spectroscopy, or MRS. It measures the biochemical changes in the brain. It also can detect tissue changes in stroke, epilepsy, and tumors. Same concerns as with the MRI. And then there's a PET scan, or positron emission tomography scan. It assesses for cell function, damage in brain tissue caused by Alzheimer's, Parkinson's, stroke, tumors, seizure focuses. It's going to light you up like a Christmas tree if you have metastasized cancer. Everywhere that the cancer is growing, it's going to glow, because it glows in areas based on cellular activity. And obviously we know in um, uh, tumors masses, we have a large amount of cellular activity with the division, rapid division. This is going to require a signed consent form. We need to explain to them they have to have an IV. They're going to not be put on any sedatives or tranquilizers before the test, because we need to potentially do that during the test. We also want them to avoid intense physical exercise for 24 hours before the test, and we want them to make sure they pee before we scan them. So we may have them do different things during the PET test to get better, the PET scan to get better imaging. The SPECT test, or the single photon emission computed tomography, is going to visualize glucose or oxygen metabolism in the brain. It's going to help us also visualize blood flow. It's going to assess cell function like the PET scan, but it doesn't give us the high resolution images that the PET scan does. They use radio labeled compounds that are injected, and the single photon emissions are scanned. The images are accumulated and examined. PET scan is preferred. Ultrasound arteriography, or Doppler flow, is going to study the flow and determine areas of constriction or obstruction in cerebral arteries. It's also going to detect if there's arterial spasm going on. It is non-invasive. It is painless. They use that Doppler wand and run over particular areas to look at the blood flow. The carotid Doppler, or carotid duplex Doppler studies, help also to determine whether blood flow is in the carotid arteries and if that's decreased or blocked. They use sound waves to make a picture. It's also non-invasive and painless. Evoked potential studies measure responses of the CNS to visual, auditory, or sensory stimulus. They're going to be helpful in detecting tumors of the eighth cranial nerve, blindness in infants, or brainstem lesions. Also really good for multiple sclerosis. It can be done in conjunction with an EEG. They use those electrodes to pick up and transmit impulses to a computer while stimulus is delivered to the patient. Of course, this is one that we will require the patient to lay still for at least for 30 to 60 minutes. Also, they may hear various noises or tone bursts. That's pretty normal. It's part of the testing. Cerebrospinal fluid analysis and culture. Like I said, we're going to be looking for infection and identifying which organism is responsible for the infection. We do obtain a CSF culture through a lumbar puncture. They look at the color, the cell count, protein, chloride, glucose in this fluid. It's also cultured to identify bacteria. And we'll measure a CSF pressure off of that. So normal levels, clear color, low white blood cell count, 0 to 8 millimeters cubed, protein of 14 to 45 milligrams per deciliter, chloride of 118 to 132 milliequivalents per liter, glucose of 40 to 80 milligrams per deciliter, and an ICP pressure of 70 to 150 centimeters of water, or less than 20 millimeters of mercury. And we do take 3 different test tubes of fluid. We want at least 3 milliliters of cerebrospinal fluid for the order. We don't want to refrigerate it, but we want to take them right to the lab. And then we learned about the plaque test, the PLAC test. It detects enzyme markers that are related to increased risk for ischemic stroke. And we're testing for the substance because it's thought to be responsible for atherosclerosis formation. And we know that increased atherosclerosis leads to potential for ischemic stroke. Okay. Woo. I wanted to bump back to the gross assessment of our cranial nerves. I might find it here. We'll see. Maybe I won't. I don't know if I got to it yet. Oh, there we are. Olfactory nerve. What are we going to do? Well, we'll have the patient smell some ground coffee or perfume or pickle juice to make sure they can smell. Optic nerve. We'll test their visual acuity with the Schnell and eye chart and visual fields by asking the patient to hold their head still and identify items in the various areas. We'll assess their pupil size, direct and consensual constriction. We'll do a combination test. We'll assess the cardinal fields and the direction of gaze with the oculomotor, trochlear, and abducens cranial nerves. With the trigeminal nerve, we'll ask the patient to clamp their jaw shut, hold their mouth against the resistance, and open their mouth widely, move their jaw side to side, and make chewing motions. We'll also test their sensation by putting warm and then cold items on various portions of the face and ask them if it's warm or cold. For the facial nerve, we're going to observe the face for symmetry, ask them to smile, frown, raise their eyebrows, tightly close their eyes, whistle, show their teeth, puff out their cheeks. For the vestibular cochlear or acoustic cranial nerve, will whisper from varying distances, see if they can hear us and tell us what was said. We'll also test their equilibrium with a Romberg test. That's where the patient stands with their feet just barely apart, their eyes closed, and you watch to see if they sway. The glossopharyngeal and vagus nerves are tested by opening the patient's mouth wide and having them say ah, and putting a tongue depressor on the first third of the tongue. And you flatten it out and observe movement of the uvula and the palate. They should rise symmetrically with the uvula at midline. You're going to assess gag reflex by touching each side of the pharynx, and there should be a brisk response. You also can test this by having the patient swallow a bit of water to make sure that everything goes down effectively. Spinal accessory nerves ask patients to elevate their shoulders with and without resistance, turn their head to each side, resist your attempts to pull the chin back toward the midline, and push the head forward against the resistance. Hypoglossal nerve, we want the patient to open their mouth wide, stick out their tongue, rapidly move their tongue from side to side, in and out, and you're going to watch for deviation from midline. You can also apply pressure to the cheek and ask the patient to push their tongue against the hand to check the tongue strength. Okay, here is a pupil gauge. We use a pupil gauge to identify the size of the dilated pupil. Um, so when we have a pupil that is one pupil is blown, one is not, a unilateral fixed dilated pupil that's unreactive to light, it may be accompanied by ptosis or a deviation. A ptosis is swelling of the eyelid or drooping of the eyelid. Um, it may be accompanied by that ptosis or a deviation to the side and downward. Potential causes is damage to the ocular motor nerve related to intracranial pressure, compression of the oculomotor nerve, a head trauma with an epidural or subdural hematoma. If we have two or bilateral dilated and fixed pupils that don't react to light, we're worried about hypoxia, like cardiopulmonary arrest, maybe some midbrain pressure, a severe central nervous system disorder, or an anticholinergic drug overdose. When we have bilateral, really small fixed pupils that are not reacting to light, accompanied by motor deficits like drowsiness, confusion, headache, vomiting, incontinence, that may be related to damage to the diencephalon. Also, it could be a side effect of opioids like morphine, or miotic eye drops, or a hemorrhage into the pons, or damage, like I said, to the diencephalon. Unequal pupil size, where both pupils are reactive to light, but there is no real underlying pathology, maybe ocular inflammation, a congenital just irregularity for them that's just there normal, even though it's not normal, or adhesions of possibly the iris to cornea or the lens, and potentially a disturbance of a neural pathway. Okay, there's checking the cardinal positions of eye movement, part of your head to toe assessment. Now we're going to talk about flexor and extensor posturing. So we talk about posturing during the Glasgow Coma Scale. Flexor posturing, which used to be called decorticate posturing, it's that top one there. So when they're doing this, they're extending and stiffening their legs, they're adducting their arms with their forearms bent upwards, their wrists and fingers get flexed up on their chest. It occurs with damage to the cortex of the brain. So it's not good. Any kind of posturing is not a good sign. And then there's decelerate or extensor posturing, in which the arms are stiffly extended and held close to the body, but wrists are flexed outward. The legs are stiff and the toes are pointed downward with plantar flexion. It means that there's damage to the midbrain or the brainstem, like a very serious injury. Sometimes this response can be lateralized, where one side of the body shows a typical flexor, but the other one shows like an extensor posturing. A patient may also display a flexor response on one side, but not and an extensor response on the other. It's important to do a neural assessment and look for changes in the patient from day to day, and that bilateral flaccidity is usually present when there's no response at all. A comatose patient, we need to perform tests to determine their brainstem function. Once we rule out spinal cord injury, the oculocephalic or doll's eye or ocular vestibular reflexes are assessed. So speaking a little bit more about the doll's eye reflex, we're going to place a hand on each side of the patient's head, and we'll use the thumbs to gently hold open the eyelids. We're going to watch the patient's eyes as the head is rotated to one side. So what is the eye doing? Is it responding? How is it moving? If the eyes appear to move in a direction opposite to that of the head movement, so you move the head to the left and the eyes are staring to the right, um, or vice versa, you move the head to the right and the eyes appear to move to the left. This is called a positive doll's eye reflex, and it indicates an intact brainstem. But if the eyes remain stationary, they don't move, or they passively follow the head motion, this is a negative doll's eye reflex, and it is abnormal. Says that there's some kind of brainstem issue. Once we make sure that the tympanic membrane is intact, we can do the oculovestibular reflex, which is caloric testing, is how we assess that. So we will have the patient's head elevated at least 30 degrees, and we'll put 20 to 200 milliliters of cold or ice water into the ear with a catheter or syringe. And then while that ear canal is irrigated, the patient's eye movements will be looked at. What will the eyes do? Well, normally we'll see nystagmus or darting away from the irrigated ear. Absence of eye movement may indicate a brainstem lesion. This caloric testing may induce vomiting really fast in patients that have a normal response. So just be aware. And then what is a neurocheck? When we talk about a neurocheck on a patient, it's important that we monitor the neurologic status of a patient, especially one that has a neuro disorder and has frequent neurochecks. Why do we do it? It's to determine whether there is increased ICP or the ICP is rising. So if they've had a traumatic head injury, or they've ingested an overdose of a drug, or they've had a stroke, or any other condition where they lost or may have lost consciousness, it's important that we do this. We'll use a flow sheet or a chart to make sure that we trend the function of each area so we can quickly identify any changes. We're really looking at vital signs, level of consciousness, pupil reaction, and motor function. Neurochecks may be ordered as frequently as every 15 minutes, up to 2 to 8 hours. Measuring of vital signs can be assigned to assistant personnel, but the gathering of data for neurochecks should not be delegated. That's very important. We want to make sure that we are able to compare the current data with previous data, and that we're carefully assessing both the neuromuscular and pupillary responses and making sure we know what's going on. Okay. Common neurologic patient care problems. We may have ineffective breathing pattern, impaired mobility, self-care deficits, dysphagia, incontinence, a bladder training program, a bowel training program, pain, confusion, aphasia, sexual dysfunction, or ineffective family coping. These are all really great nursing diagnoses that we can create goals and also interventions for. And that is the end of your chapter 21 recorded PowerPoint. If you have any questions for me, don't hesitate to touch base. I do want to just mention a couple more things that were important for this chapter before I let you go. The first is if the patient is unconscious, it's important that we keep their mouth clean. Why? We don't want their parotid gland to become infected. Oral care is very, very important in our comatose and unconscious patients. A second thing that I really want you to know is that if the patient can't shut their eyes, there's got to be something that we're doing to cleanse their eyelids, or provide artificial tears or lubricant, something like that, so that they don't get keratitis or a corneal ulceration. It's very important that we're examining the eyeballs each day for signs of inflammation if they're not able to close their eyes. Also, if we are making sure that the patient is doing therapies or working towards making progress. We need to make sure that we remember these patients are going to tire out easy, and it's very important that we space apart their tasks so that their energy is available and they're able to actually make progress. Dysphagia, we know that they may be on a specific diet, so be careful. Also, if they have difficulty eating, they're at risk for nutritional disorders, but also aspiration pneumonia. We want these patients sitting up to eat in a high Fowler position, and then depending on how bad their dysphagia is, they may have that special diet or be tube fed. Bladder training programs. It's really important that we do bladder training programs with a patient that has some loss of normal bladder function. Why? Because they can cause all kinds of issues if we're not getting them on some kind of bladder reconditioning program. Number one, they may get UTIs or they may get urinary stones. We also need the patient to be allowed to be free. They can be comfortable. They know that they're not going to have any issues with incontinence. They don't have to be embarrassed. They don't have to lose self-esteem. We'll do a bladder function assessment to determine like how much we're realistically going to be able to recondition with the patient. And then we will design that bladder reconditioning program and make sure that their mental and emotional ability to cooperate is taken into account and that they are active participants in the bladder training program. Some spinal cord injuries and lesions produce what's called as a cord bladder or neurogenic bladder. And these patients are not aware that they even need to go to the bathroom. They must be trained to go to the bathroom on a schedule and to initiate voiding and emptying the bladder in some way. Okay. Usually you start bladder training programs with a 2-hour schedule for toileting. You want the patient to drink 2,000 to 3,000 milliliters of fluid while they're waking during their waking hours or from the time they wake up to 6 p.m. You try to stay away from like caffeine or alcohol or soda after dinner because they can cause a patient to have to go to the bathroom more often. And then you just put them on this toileting schedule so that they're able to train their bodies to use the bathroom. Bowel training is very similar. It corrects incontinence and prevents constipation and impaction in patients that have neuro disorders. You're also going to be putting these patients on a schedule for going to the restroom. They may need to increase their liquid intake or take a stool softener. Potentially, there will be a planned regimen for suppositories or enemas, and maybe even like a manual stimulus to produce a bowel movement. Okay. That's good. Remember the number one rule with aphasia, we don't ever treat a person like they're incompetent or unable to understand a conversation because usually their inability to communicate is not related to a lack of intelligence or they can hear and understand everything that you're saying. They're just not able to verbalize what they want to say. So give them time to respond to your questions. Don't ask more than one question at a time and make sure that you're just very patient with them as they are working on their speaking and language skills. Okay, thank you guys. Good luck.